Hello, everyone. For those who weren't able to join us last time, my name is Nita Kessler, and as Operations Manager for Capstone Performance Systems, I'm very glad to welcome each of you to the fourth session of our ICD-10 webinar series. These webinars are recorded and available for download on our website, www.capstoneperformancesystems.com, by navigating to the ICD-10 Support tab on the top menu. The PDF handout of today's slides is available on the Start Meeting event webpage, where you can also find the handouts for the previous sessions. Capstone is pleased to sponsor this series for our PACE clients, friends, and the larger PACE community. We have been helping PACE organizations improve documentation, compliance, and revenues for over 10 years and have had the pleasure of working in over 2/3 of the programs in the U.S. We've learned a lot over these years and hope to share some of that knowledge with you today. Capstone also offers additional training and supports to our clients, so feel free to contact us if you have any questions about our services. At the end of this presentation, we will take time to answer any questions. At that time, if you do have a question, please press *6 on your phone and you'll be entered into the queue. I now want to introduce Angie Ladd, RN and Certified Coder, who is head of our coding department here at Capstone.
Good afternoon, everyone, and welcome back to Webinar 4. We are going to talk about the respiratory disorders, documenting for COPD, asthma, chronic respiratory failure, malnutrition, and skin ulcers. And I have also added musculoskeletal disorder to this webinar as well. With me today is our guest presenter, Pat Sherman. Pat is a registered health information administrator and professor in health information technology. What I want to talk about today with you is kind of going to reiterate what I said last week at webinar number 3. These webinars are not to teach you how to code. That would take an extreme amount of time. What our goal for you is to help you understand what the changes in ICD-10 are, and also to help you realize that the documentation will need to be increased because the specificity of ICD-10 has extremely increased. There are still going to be unspecified codes in ICD-10. However, I think because we are starting new with ICD-10, that is the best time to just start fresh and say, listen, we have to beef up our documentation. We don't know if Medicare is going to put forth a requirement to not use unspecified codes. We don't know if that will happen. So if that does happen, we want to be sure that we're already documenting as we should be. Having said that, again, as Nita said previously, at the end of the session, we will take some questions. Just press *6, to be entered in the queue, and we should be good from there. And without further ado, we will get started. Pat, would you like to go ahead and start?
Yes. Good afternoon. Happy to be back. And again, good afternoon to the audience. Our objectives today are to provide a summary of Webinar 3. We're going to review Chapter 10, Diseases of the Respiratory System, specifically the J category. Also touch upon Chapter 12, Diseases of Skin and Subcutaneous Tissue, which is the L category. We're going to review Chapter 4, specifically Malnutrition, the E category, and overall review documentation and coding for COPD, asthma, and chronic respiratory failure, along with reviewing the documentation and coding for malnutrition and ulcers. Now, starting with Chapter 9, the circulatory system, we did establish the need for much more specificity for atherosclerotic heart disease. Hypertension codes now includes benign, essential, and malignant because the hypertension table has been eliminated. The category begins with capital I, not to be confused with the number 1, and that's for I for circulatory, along with tobacco use and exposure requirement. Review of Chapter 9, we did establish the fact that we are to state causal relationship between hypertension and heart disease. Along with hypertensive heart disease, with CKD and or heart failure, there needs to be an additional code for this stage of the chronic kidney disease and the type of heart failure. Heart failure codes now include congestive in the description, and atherosclerotic heart disease offer combination codes in ICD-10. The combined codes of atherosclerotic heart disease now are with angina unless otherwise specified. We're wanting a specific native, bypass, graft, or transplanted heart. This is not new for 10, but it is rarely documented to specify or with specificity in 9, whereas it certainly should be. Atrial fibrillation and atrial flutter, now there's much more specificity. The AFib codes, for example, paroxysmal, persistent, and chronic. For the A-flutter, codes exist now for typical or atypical. There's still an unspecified for both conditions, and again, tobacco use and exposure requirement. So that's basically the salient features of those category changes in 10 that we brought up last week. If there are any questions, if not, Angie?
Hi, everybody. I think I have an issue with my start meeting, so if you give me just a few minutes, I am going to try to reload that. It was working fine, and then it decided not to work fine. So give me 1 second here. Let's try this.
Good.
Are we good now?
Yes.
Yes, Angie, I can see it now.
Good. Okay. I don't know what happened. I didn't touch anything. As often I hear from my kids. I didn't touch anything. Okay, let's get back to where we were. Okay, so as Nita said previously, the slides and the recording are available on the website, and you see it right there, and you just go under ICD-10 preparation tab, and you can find everything that you need for this one and the previous webinars. Okay, so let's talk about the respiratory conditions. So there are more codes for COPD. Chronic respiratory failure now includes an option for with hypoxia and with hypercapnia. It's not required, but that is an option, and we'll get to that when we talk about respiratory failure. Again, in this category, you do have the tobacco use and or exposure code addition, and the asthma category is a lot more specific as well. All right, so COPD. So in ICD-9, COPD had one code, 496. That was it. And it was chronic airway obstruction, not elsewhere classified. This included nonspecific lung disease, obstructive lung disease, and obviously obstructive pulmonary disease, COPD, not otherwise specified. So here's the comparison to ICD-10. In ICD-10, the COPD code, category code, is J44. And you can see and I think I do have a slide that does show the comparison between them. You can see that in ICD-10, chronic obstructive pulmonary disease includes all of the following: asthma with COPD, or chronic obstructive asthma. So chronic asthmatic obstructive bronchitis, chronic bronchitis with airway obstruction, bronchitis with emphysema, so on and so forth. All of those conditions you see there are now included in the J44 category, which we'll talk about. But what I want to point out is that in 9, you had a separate code for asthma with COPD, or otherwise known as chronic obstructive asthma. In 10, it is now in 1 code. Right. Okay, so additional notes. The additional notes for ICD-10 directs you to that if you say that they have chronic obstructive asthma or asthma with COPD, you need to code the type of asthma if applicable, which it would be if you said it was chronic obstructive asthma, and that is category J45. I do have a slide that talks about this, so we will explore that further here in a few. Again, you have to identify the tobacco use and or exposure. The other categories we have for J44 are COPD with acute lower respiratory infection. You will need an additional code to identify the infection. This would be your acute bronchitis. So if you said they have COPD with acute bronchitis, you will need 2 codes, J44.0 and the code for acute bronchitis, which I have listed there. COPD with acute exacerbation still is a code. It is J44.1. It includes decompensated COPD with exacerbation. And again, I said it does, J44.1, the COPD with acute exacerbation excludes COPD with acute bronchitis. So that would be 2 codes, J44.1 and J44.0. You also, again, have COPD unspecified. But like I said, I really encourage you to try to not use unspecified codes when we switch to ICD-10. Yes, it will be easy, but I just think that we should all be documenting to specificity. You're supposed to document to specificity anyway, but we should really start to do that. Okay, so here it is, the comparison to ICD-9, or from ICD-9 to ICD-10. So as I said, 496 was 1 code, COPD. It is now J44. Then you had a separate code for asthma with COPD, asthma unspecified, chronic obstructive bronchitis, and emphysema. You have several codes there. So with ICD-10, you still have several codes, but you have more of your conditions inside of your COPD category, which, as with ICD-9, you did not. That's all you had was COPD. Okay, here's the most important thing, and I see this all the time, and I want to make sure you're documenting it correctly. For HCC 111, if you want to get HCC 111, you must document chronic obstructive asthma or asthma with COPD. This is only for the asthma component. A lot of times I'll see did I lose my screen again?
Yes.
I can still see it, Angie.
No, you know what? It's not. I
cannot see it.
I'm guessing I'm having internet issues because it's just shutting off for me. All right, let's try this again. I apologize, everyone. I don't know what is going on in my neck of the woods, but
okay.
I'm not. Okay, here we go. Okay. Are we good now?
Good.
Yes.
I'm losing signal. I think that's the problem. Okay, anyway. So if you want to say that somebody has asthma with COPD or that it's chronic obstructive asthma, the only way you're going to do that and get HCC11 is if you document it as I have it listed here. It must be chronic obstructive asthma or asthma with COPD. Because if you just say asthma and COPD, or document it like this, COPD/asthma or COPD with asthma, you're not going to get the HCC. The reason why is because of the way it is indexed in the ICD-10 code book. It's the same way for ICD-9 realistically. So unspecified asthma, which is J45.909, does not map to an HCC. And if you just say asthma and nothing else with it, that is what is going to be coded, J45909, and you're not going to get HCC11. So please document it this way, chronic obstructive asthma and asthma with COPD. I know it doesn't make any sense, but if you document it the other way around, COPD with asthma, it doesn't, for some reason, it just does not code out to the right code to map to HCC111. Okay, so documentation example. Mrs. Smith is a 72-year-old, well, hopefully, Mr. Smith is a 72-year-old male with COPD, worsening gradually over the past year despite compliant use of nebulizers and rescue inhalers. CFTs demonstrate a decline in lung function over the last 12 months, now with the constant use of 2 to 3 liters of O2 nasal cannula at home for the last month. He cannot walk any distance without significant shortness of breath and overall discomfort. Vital signs are 138/84, heart rate is 88, respiratory is 16, at rest, and O2 set is 90% on 3 liters. The assessment plan is COPD with chronic respiratory failure with hypoxemia, continuous O2 at 3 liters, followed with pulmonology. The codes would be COPD unspecified, because yes, you can still use that, and J96.11, which is chronic respiratory failure with hypoxia, and we are going to talk about that here shortly. Okay, asthma. I'm going to go back to asthma. So asthma, which is J45 category in ICD-10, includes all of that you see here. The difference between ICD-9 and ICD-10 with asthma is that J45 includes all of these diagnoses: allergic asthma, allergic bronchitis, extrinsic, intrinsic, so on and so forth, whereas in ICD-9, they were all separate codes. So intrinsic asthma was a separate code. Extrinsic asthma was a separate code. Chronic obstructive asthma was a separate code, so on and so forth. But in ICD-10, these all fall under one category, J45. And again, you need an additional code for tobacco use and exposure. There is more specificity, as I said. So now, when you're coding asthma, they're asking you to say, is it mild intermittent, mild persistent, moderate persistent, or severe persistent asthma. You also have a category for other and unspecified asthma. All of those categories except the other asthma include the following 3 subcategories. So not only are you going to have to say, is it mild intermittent asthma, but then you're going to have to say, is it uncomplicated, is it with an acute exacerbation, or is it with status asthmaticus? So there's where your more specificity comes in. Other than that, it's essentially the same. The difference is in the specificity and the code combinations. Other codes in the asthma category are, as I said, unspecified asthma, which includes asthmatic bronchitis, childhood, and late onset, and your other, which is exercise-induced cough variant and other, truly other, whatever that may be, asthma. Okay. Emphysema is category J43. Again, tobacco use exposure identifier. In the emphysema category J43, it includes unilateral pulmonary emphysema, panlobar, and central lobar emphysema. The difference between emphysema in 9 and emphysema in 10 is the same as asthma. Central lobar, panlobar, and panasonar were all under one code. Really, in ICD-9, there was 2 codes for emphysema, 492.0 and 492.8. So as you see, there are a lot more codes for emphysema in ICD-10. It is the same. It just separates them out into individual codes. So you will see unilateral is a code, panlobar is a code, Central lobar is a separate code. And continuing on, other, which includes emphysematous bleb, is its own code. Bullous emphysema is its own code. As I said, in ICD-9, you had 2 codes for emphysema. That's it. So a documentation tip that I have for you is that if you have emphysema documented as being present with chronic bronchitis, it is not coded in the J43 category. You will have to refer to the J49. My best advice is to just be specific in your documentation. The coders will figure out what they need. And if there's not enough documentation, they're going to tell you. But if you take anything from ICD-10, just take the fact that you need to be specific. And I hope that with these webinars that we have really, that we have shown how specific it really needs to be. Okay, continuing on. Documenting and coding for chronic respiratory failure. Respiratory failure not elsewhere classified is category J96. There's very little change from ICD-9. The only exception is now chronic respiratory failure has its own code. So in ICD-9, respiratory failure was included with the other diseases of the lung category, which was category 518. So this category includes respiratory failure, acute, J96.0, chronic, 0.1, acute and chronic, 0.2, and unspecified, 0.9. There are additional codes under each of those categories, under each of these categories, acute, and chronic, and unspecified. There are additional codes under each category that require a 5th character. That 5th character will give you the with hypoxia or with hypercapnia, or unspecified if you don't know, or if you don't document. If it's not documented if they have hypoxia or hypercapnia, you still have the unspecified code. But I don't want you to use that. I want you to document it. Anyway, example, chronic respiratory failure with hypercapnia is J96.12. So the J96.1 is the chronic. When you add the 2, it adds the with hypercapnia. Same documentation requirements apply in ICD-10 as in ICD-9 for documenting, and well, not really documenting necessarily, but for supporting chronic respiratory failure. Your participant must essentially be on continuous oxygen, be hypoxic at rest or with very little activity, like I said, and beyond the oxygen. If you're on PRN oxygen, chronic respiratory failure is not going to be supported. So I urge you to make sure before you assign this diagnosis that they meet the criteria for chronic respiratory failure. The other thing, what is not included in this category is post-procedural respiratory failure. You would refer to the J95 category, 821 or J95B22. There are other respiratory disorders in ICD-10, and I'm not going to go into them. I'm just going to show you what they are. You do have pulmonary insufficiency, which is lung disease not otherwise specified, J98.4. Respiratory disease not otherwise specified, and respiratory insufficiency, none of which I urge you to use because they're not specific. So if you know what it is, you should document that. The J98 category also includes some emphysema conditions, interstitial and compensatory emphysema. They do not go under the J43. They will go under J98. Okay. Now that we've gotten through respiratory conditions, let's talk about malnutrition. This is short, one slide. The biggest difference between 9 and 10 in malnutrition are the codes. In ICD-9, you had one code, 263. All of these were under one category, one code, the category 263 code. In ICD-10, it's still going to give you malnutrition, moderate nutrition, and severe, but it's just in different categories. So all of the codes are E44, which is protein calorie malnutrition, and you have your degrees, mild E44.1 and moderate E44.0. Protein calorie malnutrition unspecified, E46. That's it. There is no other code that's the only one. Again, I urge you to not use an unspecified code. If you are not sure what degree of malnutrition, then I suggest consulting with your dietitian and have he or she give you some guidance on that. We should use mild or moderate. Then you have E43, which is your severe protein calorie malnutrition. I would use this cautiously unless your documentation is very specific. I have seen this documented before, but you really want to make sure your documentation is there if you're going to say someone has severe protein calorie malnutrition. I would just be cautious about that. Other categories for malnutrition are a post-surgical malabsorption, which is actually not in the E category. It is K91.2, and that would be your surgical complications, which is why it is not in the E category. Okay, that's all I have to say really about malnutrition. Documenting and coding for pressure and non-pressure ulcers in ICD-10. There are two categories for skin ulcers in ICD-10. There is a L89 and L97. So we're going to talk about pressure ulcers, which is L89. These are combination codes. They classify pressure ulcers by their anatomic site, laterality, and their stage. It's actually pretty exciting. New for 10 is these codes now include the stage and the area. So if you remember from ICD-9, you had to say it was a stage 2 of the heel, and you would be required to have a code for the stage and a code for the area, and you do not any longer. It is just really your documentation doesn't have to change all that much because you're still going to say what the stage is and you're still going to say the area. You are going to have to say where it's at. And usually I didn't really see much of a problem with that in the documentation that I've reviewed over the years. One thing I do encourage is please put the stage. If you don't know the stage, again, consult your nurses or your wound nurses or whomever is taking care of that. You can actually review their documentation and use what they have, but the diagnosis must be documented by the providers. So anyway, include the stage and area. It includes descriptive terms identifying the stage clinically, except for unstageable. It doesn't describe it, just says unstageable. And it also notes healing ulcers. Now, this did not change from ICD-9 realistically. In ICD-9, they still told you, they still clinically described the stage, and they still described it as healing ulcers. They just want to make a point of that if you did not know that they do. You have to now document the laterality of the area, right and left, and for the back, it is upper and lower back. So we need to know where it is on the back. So an example is the stage 2 pressure ulcer of the right elbow would be L89.012. You have healing pressure ulcer of the right elbow, pressure ulcer with abrasion, blister, partial thickness skin loss involving epidermis and or dermis of the right elbow. So that is what, when I was telling you that it talks about the clinical stage and that it's a healing, this is what it would say. So that code says this, it could be a healing pressure ulcer, and stage 2 means abrasion, blister, partial thickness skin loss involving epidermis and or dermis and of the right elbow, as I said. So that's what that's going to tell you. Okay, documenting and coding for pressure ulcers, continuing. Another difference from 9 to 10 is that, like I said, that there's no longer separate categories. I'm sorry, there is separate categories for pressure and non-pressure ulcers. Previously, they were under one category. So, as I said, you have L89 and L97. L89 is pressure, L97 is non-pressure. And in ICD-9, you just had category 707. So there are no stages assigned for non-pressure ulcers, and I'm going to show you the comparison here in the next couple slides between these stages. So make sure if it is a non-pressure ulcer, you do not put stage 1, 2, 3, or 4 because you shouldn't for non-pressures. Descriptions of the pressure and non-pressure ulcers are not the same, and as I said, we're going to talk about that here in just a second. Non-pressure ulcers are described by the depth, not by the stages. So healing pressure ulcers. For healing pressure ulcers, you need to document the appropriate clinical stage for the healing ulcer. So in other words, you didn't upcode in 9, you don't upcode in 10. So an example would be a stage 3 pressure ulcer becomes a healing stage 3 pressure ulcer. If it's a stage 3 ulcer, when you originally assess it, as you continue to assess it, it needs to then, and it is improving, it still needs to be considered a stage 3 ulcer. It would just be a healing stage 3 ulcer because obviously the skin, everything that's lost doesn't replace itself. It just is replaced by granulation tissue, scar tissue. So it still needs to be documented as a healing stage 3. So here's the comparison between the categories, the clinical description of pressure and non-pressure. As you see, it's a lot different. So I'm not going to review them all because I know that you all know what stage 1, 2, 3, and 4 mean. But what I want you to note here is the difference. So the description of non-pressure is, you have limited skin breakdown, you have the fat layer exposed, then necrosis of muscle and necrosis of bone. So as I said, it's a depth measurement more than it is changes of, yes, you do measure depth and pressure, but what I'm saying is it does not get reported in stages. Okay. We are now going to talk about musculoskeletal disorders, and I am going to turn this back over to Pat to present this to you.
All right, thank you. Chapter 13, Musculoskeletal in ICD-10 CM. The range M00 to M99. Almost every code in this chapter has been expanded in some fashion, with the expansion including very specific sites as well as laterality. Conditions have been moved to MS and connective tissue chapter in ICD-10 as compared to where the condition was located in 9 chapters. For example, gout, osteomalacia, and malocclusion are now included. So let's talk about arthroplasties, arthropathies. We now have in 10 infectious, inflammatory, and arthrosis. For example, rheumatoid arthritis, M06.9. For systemic connective tissue disorders, such as systemic lupus erythematosus, M32.9. Dorsopathies, deforming, and other dorsopathies, such as cervical disc degeneration, M30.3. The soft tissue disorders are included, other osteopathies, chondropathies, and other. So there's been an expansion in that area, and the biggest change has been specificity, site bone, joint muscle, laterality, encounter codes, and coding of pathologic fractures. Now, for encounter codes, there's some uniqueness going on here: initial, subsequent, and sequela. And for the coding of pathologic fractures, the osteoporosis with current pathological fracture is a noted difference as well. Now, the seventh character that relate to the encounter codes. Remember, these following extensions are required for coders to use in Chapter 13, and these present pathological or stress fractures with codes M84.3 through M84.6. For initial encounter, it's going to end in an A. For a subsequent encounter for fracture with routine healing, the code will end in a D. For subsequent encounter with delayed healing, it's a G. K, subsequent encounter, non-union. P, subsequent encounter with malunion, and the code will end in an S for sequela. The encounter codes, the difference between the encounter codes for pathologic fractures versus traumatic fractures. The 7 character extensions for codes in this chapter, which is chapter 19, traumatic fractures with codes S02 through S99. These codes will end A for initial encounter for a closed fracture and end in B for initial encounter for an open fracture. Seventh character extension A, initial, is for use when the patient is receiving active treatment for the fracture. An active treatment, according to ICD-10, is surgical treatment, emergency department encounter, and evaluation and treatment by a new physician. Character D, routine healing, is used when the patient is being seen in an encounter after the patient has completed active treatment. So subsequent encounter for routine healing includes cast, change, or removal of internal or external fixation device, medication adjustment, other aftercare, and follow-up visits. Pathologic fractures. They're now classified 3 different causes, rather. They now have their own category, and as opposed to in ICD-9, they were all under a 733 category. Now, the 3 different causes: 1, due to neoplastic disease; 2, due to other disease; and 3, due to osteoporosis. So look at neoplasm. We code neoplasm, the pathologic fracture in a neoplastic disease. Example, shoulder, initial encounter. The code would look like this: M84.511A. Due to other disease, M84.6, and code the underlying disease. On the next slide, category M80 in ICD-10 CM classifies the type of osteoporosis in addition to the site of a current pathological fracture into one combination code. We also have age-related postmenopausal osteoporosis, M80.0, and other osteoporosis, M80.8.
So one thing I want to point out here is that the change here that you need to know has to do with the coding and the HCC, because in ICD-9 you were able to code a pathologic fracture of the vertebra or the femur with, if you had continued treatment of it for pain, for example. So what we taught you is that if you have somebody that has a compression fracture or pathologic fracture, something a fracture that's due to osteoporosis or neoplasm or something, and they're still having pain from it, and you're still treating that pain, you can still code it. This was your 733.13 in ICD-9. It risk adjusted. It was an HCC, and it would go to HCC 169. In ICD-10, this does not happen anymore. And the reason why is because of the encounter code. So in ICD-10, only the initial encounter, which is the seventh character A, for pathologic fractures of the vertebra or hip will risk adjust. And that will either be HCC 169 for vertebral and HCC 170 for the hip. So, off the record, what I would, and I don't want to say advise, what I think might be a good idea is to look at your participants at this point and see if there is anybody with a pathologic fracture, a true pathologic fracture, that you are still treating in ICD-9. Just saying. That's all I'm going to say. It does not risk adjust in ICD-10 because it's only the initial, which more than likely will not be captured. Because most of what you are having come into your facility is those who already have it, have a pathologic fracture and are still being treated. Okay, so I'm going to go on. I'm going to let Pat continue with osteoarthritis.
All right. Osteoarthritis, primary, secondary, post-traumatic. No longer an unspecified code. It's this section is very much site-specific. In ICD-10, only osteoarthritis unspecified is M19.90. It must state primary or secondary. There's no bilateral code. We have to code right and left for bilateral. For example, osteo secondary bilateral shoulders will show two codes. The .211 for the right and the .212 for the left. There is an unspecified code, but documentation really should be specific so we can capture and code appropriately. Generalized OA falls under M15, polio osteoarthritis. Primary generalized, M15.0, secondary generalized, M15.3, and unspecified generalized, M15.9.
So what to take away from arthritis in ICD-10 is that you do have an unspecified code, but
yes,
it's only for osteoarthritis. That's it. It's not for, it's osteoarthritis unspecified, as Pat said, it's M19.90. You really, for ICD-10, need to state if it's primary or secondary osteoarthritis. If it's only of the right shoulder, then that's fine. You can say it, but if it's bilateral, just know that you're going to have two codes for it, and you need to code two codes for it. And again, there still is generalized. It just falls under a different category. So the osteoarthritis category is not M19, but generalized OA falls under M15. And again, it's primary, secondary, and unspecified. But we really should just start to be specific on, is this primary osteoarthritis or is this secondary osteoarthritis? Obviously, if it is something that you do not know, we still do have the unspecified, but it is it's a lot more specified in ICD-10. So we just need to, again, you have your primary, secondary, and your post-traumatic. So we just need to be specific about osteoarthritis. Okay, that is all we have for webinar 4 today. One thing I will mention, I was under the impression that you did get an email, but I'm going to, or a notification rather, but I'm going to make mention again. The next webinar, number 5, is going to be the last one. We decided that we were going to combine the content because we were able to do so, and so the next webinar is Thursday, September 3rd, and it will be the last one. So we will not have one after the next one. It is still going to be at the same time, 2 p.m. Central, 3 p.m. Eastern. You will, again, receive a survey by email. And if you have any questions that we are not able to get to today, you can feel free to email Dr. Shamp at rshamp@cpstn.com or myself, alad@cpstn.com. And if anyone has any questions, we will take those now. Hello?
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 Oh, hi. This is Rico from Community Life in Pittsburgh.
Hi.
Hi. It seems like I always have some kind of question about, is this documentation really necessary? But on the osteoarthritis, they, I don't know about anybody else, but they've never used primary or secondary osteoarthritis.
You're right.
Because it's never, I'm not saying it's never secondary, but it rarely ever is secondary. So is that something that might fall under the category of a default? I know that maybe there isn't a coding guideline. If they don't specify that it's secondary, can it default to primary, or is primary going to really something we have to educate them to specify?
What I'm going to show you is this is my coding book, my online coding book. So I'm going to show you chapter M19. So what we have is, as we talked about before, you've got your M19 for your osteoarthritis, other and unspecified, but it's still listed as primary, and then by site, as you see, shoulder, primary elbow, primary wrist. Then it goes into post-traumatic, same thing, and then it goes to secondary. You do right here have an osteoarthritis unspecified code. It is the only one. So it's M19.90. That is your only unspecified arthritis code. So I don't know if you can see that, but it's unspecified osteoarthritis, unspecified site. So which includes osteoarthritis, arthritis, and arthrosis not otherwise specified.
Right. But what if they just say, osteoarthritis of the knee, of the right knee, or whatever knee? That's part of the problem. Let me go to 15. That's part of the problem. When you look it up in the index, and I don't know, because there's no code, like I said before, when we spoke, there's no coding guideline. Not that there's not a coding guideline, but there's no AHA clinic. So when you look up osteoarthritis, I'll just show you. Here. Let's do. You were going to talk about osteoarthritis of the knee. Let's see.
M17.
Yep, takes you to M17.
Mm-hmm.
So yes, osteoarthritis of the knee unspecified. We do still have this code. It's just going to be in a different category.
Right, but what if? Okay, what if they specify the right knee but don't specify the type of osteoarthritis. Should you still use that code then?
You have, you probably would, because there is, if you look at category M17, the only unspecified code you have for just truly unspecified is just, osteoarthritis of the knee unspecified. So at this point, what I would say is that you might get a query from one of your coders that says, do you know if this is primary or secondary? This is the only choice we have. Do you have anything to add on that?
Well, just looking at the category, at the 0, it's bilateral primary. At the 0.1, it's unilateral primary. 0.2, it's bilateral post-traumatic. 0.3, unilateral post-traumatic. At 4, it's other bilateral secondary. 5 is other unilateral secondary. And 9, osteoarthritis of knee unspecified.
Right, so
there's not exactly a default code other than just picking just from the alphabetic index. It does go to knee without any other specification, which goes to the 9.
Right. It's just you just don't get the laterality if you do unspecified.
Yeah, there's a couple different instances where where ICD-10 seems to take away your unspecified. In this case, they added the laterality, but they didn't give you an unspecified. If you specify the side, and then
right.
You don't specify the type, they don't give you that option. Which, again, I think that most PACE providers, I have never seen primary osteoarthritis ever.
And you're right, and I haven't either. But if you look, look at generalized. Mm-hmm. That's all you get generalized. So when you say generalized osteoarthritis, if you're not saying primary or secondary, you're just getting this. And I think the reason why ICD-10 did that is because of the fact that the coding guidelines tell you that you need to be specific. So, like I said, whether they decide to, deny reimbursement for unspecified codes is yet to be seen. But, we just don't know.
Right.
I hope they don't, because I think a lot of people, and I'm not talking about just the PACE world, I think a lot of people will be in trouble.
Yeah.
Well, I don't think that they'll. I can't see that they'll deny it. I just had come off a call from from CMS, and they said, unspecified codes are perfectly fine in our book. I don't know. Maybe they'll change that over the. But anyway, okay, I've taken up enough time, but thanks very much for addressing that. Thank you.
No problem.
Thank you.
Thanks. Anybody else?
Yes, sorry, I have a question. This is Heidi from Life Rewards.
Hello.
Hi. Going back to the 7-character extension for initial and secondary, I keep going back and forth and speaking to different people, and I see that you wrote that underneath the 7-character A initial for active treatment, it says evaluation and treatment by a new physician.
Yes.
So if we send a participant to the ER because they fractured a wrist, and then they come back to our care and our doc then evaluates them and decides whether or not they need to go to the ortho or what have you, is that an initial encounter for our doc, even though the ER started the actual treatment?
I'm not sure that there is a designation of who the new physician is. So by your example, yes, that would be correct. So, because it says that you can, so in an outside PACE world, the same thing would happen. They would go to the ER would send them to an ortho. So that would be the new physician. It's just in PACE, they're sending them back to you. So I would, at this point, because there's no further direction, yes, the new physician could still be your PACE doctor.
I agree.
Okay.
Yeah.
Thank you.
You're welcome. Any other questions? Well, if there are no further questions, we will conclude this webinar for today. And again, if anybody has any further questions or something that you think about, please feel free to email either Dr. Shamb or myself, and we will do our best to answer any questions that you may have. And we will speak again on the next webinar next week. Everybody have a great day, and thank you for joining. Bye-bye.
Thank you.